brief intro. We are all welcome to the PCOS webinar. That's the Polycystic Ovarian Syndrome, Acne, Esthetism, and Infertility. I trust the weather is treating us fine so far. So we're glad to have you here. Just a brief introduction. I am Dr. Ben Oko with Dr. Connect. I'm a medical doctor who is passionate about creating awareness and prevention of disease at the community level. And so if you've not heard of Dr. Connect before, I'll just give you a brief intro of what Dr. Connect is. The Dr. Connect is a subsidiary of Just Small Group and is a foremost telemedicine organization which is on a mission to use mobile and disruptive technology to make healthcare instantly accessible and affordable. And so we offer 24/7 round-the-clock telemedicine consultation via the Dr. Connect app, which can be downloaded from the App Store or the Play Store. And so if you are here, once the app gets downloaded, sign up, you get 30 days free to make use of it. So we also have a partner lab called Life Pro, located at Adult House 15 CIPM Avenue, Alausa, where you can do your health checkup, lab tests, or specialist appointments. You must have seen some of our content shared on WhatsApp or your social media pages or sent to your email. If you haven't, kindly check our YouTube page called Dr. Connect so you can get enlightened on general health topic. And so the topic for today really is polycystic ovarian syndrome. From the flyer, the banner in the webinar, you'd have seen some symptoms associated with it, such as acne, hirsutism, infertility, and the likes. And the reason why the PCOS is very important, as I said, September is PCOS Awareness Month, and it's a common and poorly misunderstood condition, and that is the purpose of this webinar, really. It affects about 1 in 10 women, and it can lead to future complications like infertility, metabolic syndrome, and the likes. And that is why being informed on time is very crucial. And so I'm not alone today. I have a very seasoned gynecologist with us, and there will also be time for questions and answers. So you can make use of the chat option if you want to leave a question. There will also be time for poll sessions that will pop up on your screen, and then just select the answers you think best. There will also be a link if you are interested in doing any investigation, any lab test or specialist appointment. You can just click on the link and register. And so before I go on to introduce our guest speaker fully, a video will be played on your screen. Do well to watch the video and then we'll take it up from there. Thank you again for joining the webinar. I'm very sure it will be an enlightening session. Okay, thank you all. And so we have Dr. Halimah with us. She'll be anchoring the webinar presentation. She's an obstetrician and gynecologist, a girls and women rights and education advocate. Dr. Halimah has over 15 years experience in medical practice. She's passionate about the total well-being of today's woman with special interest in reproductive endocrinology, fertility care, and infertility management. She actively serves as a trainer, volunteer, and mentor to several young people with numerous organizations. She's an alumnus of the University of Lagos. She's also a fellow of the West African College of Surgeons and member, National Postgraduate Medical College. She is happily married with children. Dr. Halimah, thank you very much for joining the webinar. I would hand over the session to you now.
Thank you very much, Dr. Gloria, for having me. Thank you to the Dr. Connect for organizing this great webinar. And I want to thank all the beautiful people that joined us today to discuss this very important webinar. I am Dr. Halimah. Can you see? Okay, my screen, Dr.
Yes, I can see. You can share your slides now.
All right, so let me see. All right, so that's good. Give me 1 minute. All right, so today we'll be discussing the polycystic ovarian syndrome, a very, very, very common syndrome in our society. And it's one of the common reasons why women visit the hospital. Unfortunately, it's also a condition that is easily misdiagnosed. Okay, I'm trying to put it on slideshow. Okay, so that's good.
Okay, it's perfect.
All right, it's okay. So you can see it clearly.
Yes, I can.
Okay, so like Dr. Gloria said, September is the month for PCOS, as polycystic ovary syndrome. And then it's important to know that we are not alone in this. This is a condition that cuts across all strata of the society, cuts across race, ethnicity. This is not a syndrome that you say, oh, it's common in the Blacks and all that. So this is something that affects everybody. So before I start, I saw this quote on the internet that is very apt. And this is like a solidarity to all women out there who have PCOS. So I am not a sufferer, I am a fighter. I am fighting against PCOS, not suffering from the disease. I don't need your pity, I need your love. And in the course of the presentation, you'll find out the reason why this is so pertinent, why this quote is like this, because in some of the presentation, if you don't take care, as in it's that pity you will project rather than support the people that are living with PCOS. So without taking much of our time, PCOS, like I said, is a very common disease. It is a common endocrine. Endocrine meaning the hormones, has to do with the hormones, the common endocrine and metabolic disorders among reproductive aged women. Reproductive meaning from the time of puberty to the time of menopause. And for PCOS, even though we said to the time of menopause, the effects of PCOS can be seen even after the menopause because of complications that it can cause in a woman if not properly managed. So it is a disorder that has so many faces and it has a lot of impact on the various aspects of a woman's life, starting from how the woman looks, to affecting the reproductive ability of the woman, to affecting the metabolic activity of the woman, obesity, the psychological well-being. There is a lot of women who get depressed when they have PCOS. It also affects the sexuality of the woman and overall the quality of life of a woman. So it is usually most often characterized by an imbalance of the sex hormones. So when we talk about the sex hormones in women, we are talking about the luteinizing hormone, follicular stimulation hormone, the progesterone, the estrogen. So those are the common ones that we know. And then the common symptoms include irregular menstrual cycle, which in the course of the presentation, I will tell you what that means and how it presents, polycystic ovaries, and then asceticism. Like I said earlier, a high percentage of people remain undiagnosed because you just hear, oh, I'm having regular menses, and then the common balance out there is you have hormonal imbalance, probably because of stress and all that, and then somewhere along the line, the diagnosis is mixed. And then find out that in over 75% of cases of infertility that are due to anovulation meaning the woman is not ovulating, over 75% of it is due to PCOS. So like I said, it's quite common and it impacts women of all races and ethnicities. it affects about 1 in 10 women worldwide. You can see 1 in 10 is quite a huge number. And then what we find out is that the prevalence ranges. You don't have a particular prevalence because there are different diagnostic criteria. So depending on the diagnostic criteria that was used, the prevalence ranges from about 3% to 18%. Studies that have been done in Nigeria have reported wide range of prevalence. So I picked a study done by Omokoye et al., which reported the prevalence of about 12.1%, and then Ugo et al. Reported the prevalence to be about 18.1%. As widely studied as PCOS is, there are still so many unanswered questions. There are still a lot of gray areas that we are not sure of. Why this is this, why does this have to be? There are so many interconnectivity, they are so interrelated that we still have so many unanswered questions. And there are so many phenotypes of PCOS. But the most common is you have 2 major phenotypes, and these are the obese. So you will find a woman who has PCOS and she's overweight, she's obese. And then you will also find a woman who is lean and she has PCOS. And then you start asking yourself, I thought they said PCOS causes obesity. So why is this woman lean and why is she having PCOS? So those are the 2 major phenotypes. But we find out that obese women with PCOS far outweigh the lean women with PCOS, and the estimated prevalence is about 80 to 20%. Now, what causes PCOS? We don't know yet. We are not sure. The exact cause is unclear to us. But so many studies have been done, and they find out that when you talk about epigenetics, this is a classical case of epigenetics, meaning that you have a complex interaction between the genetic composition of the individual and the environmental traits. Now, studies have been have shown that twins, there is a twin study that found PCOS in twin children. So it's not impossible that if a mother has PCOS, a child can have PCOS, a sister can have PCOS. And like I said earlier, it develops during the early puberty years. Puberty is, because I know this is a mixed audience, puberty is when a woman has achieved the secondary sexual characteristics, and the hallmark of puberty is menstruation. So like I said, the pathogenesis, that is the cause, the root cause is quite complex, and it has so many facets, it's multiple. I deliberately put this picture here so that we can have a clear, I want us to look at a woman starting from her brain down to her ovaries. And for the benefit of our listeners, I'm sure we know what the ovaries is. I can always tell people ovaries is like the powerhouse of a woman, where the eggs are produced, and these eggs are the eggs that essentially makes us ovulate, ovulated. We need the eggs for fertility and then for menstruation. So we find out that PCOS is something that has it's a disorder that affects, that has its genetic that has its root cause from the brain, connection between the brain here to the ovaries. And then when you talk about the ovaries, we are talking about the hormones of the ovaries, we are talking about the cells of the ovaries. So we usually say that the hypothalamus-pituitary ovarian axis, meaning the hypothalamus of the brain, the pituitary aspect of the brain, and the ovary. And it's so complex that you found one interrelated. Some hormones are so high, and then because they are so high, they cause production of some further hormones that now predisposes the woman to hyperandrogenism. You have a lot of androgens. Androgens are like male hormones. We all have a lot of androgens. We all have androgens in us because in a certain level, but in PCOS, these androgens are elaborated, they are high. And then when they are high, they cause a dysfunction in the body. And then the dysfunction that they causes makes it practically difficult for a woman to ovulate. Also, insulin on its own in PCOS, insulin is a hormone that regulates glucose metabolism, that's sugar, that regulates it in our body. And it has been found out that there is insulin resistance in people that have PCOS. And apart from insulin resistance, there are other mechanisms that make insulin production very high, which we call hyperinsulinemia. And then when we have that, you have insulin resistance, you have hyperinsulinemia, there is a lot of sugar in the body. So there is a tendency for type 2 diabetes mellitus to develop. With that, with a lot of sugar not regulated, there is obesity with its own attendant issue. All these, the metabolic syndrome causes cardiovascular disease. And so you can see it's complex. It's I have another diagram here. So in the hypothalamus is the part of the brain that is responsible for the gonadotropins. Now, the gonadotropins are the luteinizing hormone and the follicle stimulating hormone. I don't want to, please bear with me, I'm trying to break this down as much as possible. So you have a complex interplay every month that one hormone rises and then another hormone decreases for us to menstruate, for us to ovulate, and for pregnancy to occur. And there is another way that all these hormones work. So for a woman without PCOS, the GnRH, that's the gonadotropin releasing hormone, are released in a pulsatile fashion. So you found the release in a certain amplitude and at a certain time. But when there is PCOS, this release has no meaning again. So you just have like misfiring, it just keeps firing, and then you have a lot of the gonadotropins in the system. Now, so you have an increased luteinizing hormone compared to the follicle stimulating hormone. And then when you have this, okay, you are going to have, pardon me, let me explain the way the normal menstrual cycle takes place so that you will understand how important this LH, FSH, that's the luteinizing hormone and the follicle stimulating hormone, are to the normal reproduction. So normally, for a menstrual cycle, let's say the most popular one, the most common one is the 28-day menstrual cycle. So we have for menses to occur, we have what we call the ovarian, the ovarian phase of the menstrual cycle, and then the uterine phase of the menstrual cycle. So from day one of the menses, that is when we start menstruating, that is our day one of the menses, you have a rise in the gonadotropins, that's the follicle stimulating hormone, that brings about the development of these follicles. These follicles are in the ovaries. So the follicle stimulating hormone starts rising, and then there is a part of this ovary, which we call the thicker part of the ovary, that you have the production of hormones. So you have estrogen being produced. You have estrogen being produced from the aromatization, pardon the big grammar, of some androgens. So you have estrogen being produced. So at a point in time, the level of follicle stimulating hormone starts decreasing. So when the level of follicle stimulating hormone starts decreasing, all the small follicles start going a check, they start dying off. So you have the development of a large one that has a lot of follicular activity. That one develops to become what we know as the dominant follicle. That one can reach up to like 20 millimeter. So it is this dominant follicle that goes on to ovulate, that extrudes the follicles, that is the egg that is necessary for fertilization. So at the time it starts occurring, so you have a rise in the luteinizing hormone. Remember that I said it's being produced in the pituitary part of the brain. So at a point in time when you get to the peak of the luteinizing hormone, about 24 to 36 hours after that, ovulation will occur. So when ovulation occurs, you have development of the corpus luteum, the uterine lining starts preparing for implantation. So you have an increase in the progesterone level that is produced by the corpus luteum, that is the remain of the eggs that is being ovulated. So when pregnancy does not occur, that is progesterone withdrawal in the uterus. So this progesterone withdrawal in the uterine lining causes the shedding of this thick endometrium that comes down as menses. Now, for a woman that has, so this is the same thing I am writing that I've just depicted in this diagram. So you have the follicle stimulating hormone. So this is the way it should be normally. But in PCOS, because there is misfiring of the gonadotrophin releasing of the gonadotrophin releasing hormone, so you have a higher amplitude of the luteinizing hormone. So what you just have is a raised luteinizing hormone. There is no pattern to it. So the follicle stimulating hormone too is being released, and then you have development of follicles. So in this case, you just have a lot of follicles, and instead of them dying off, and then you have a bigger one going into ovulation here, you just have small follicles. The LH remains constant, as in there is no surge of this LH like we have here that will bring about ovulation. And if there is no ovulation, there can be menstruation. And if there is no ovulation, there can be fertility. I'm trying to just break this down so that you can understand. So in doing that, with the high level of the luteinizing hormone, a lot of activities are also happening in the follicles. So you have a lot of hormones, the androgen hormones that are supposed to be produced at a certain level. You now have them excess. So you have a lot of androstenedione hormone, like androstenedione and the like testosterone in the system. So you have androgen excess. With the androgen excess, you have the symptoms of hirsutism. So you have facial hair, where in different places you have the male pattern of hair growth in female. Like I said, because there is no ovulation, then it becomes difficult for the woman to get pregnant. The polycystic ovaries is the one that I have explained, due to the follicular stimulating hormone just staying there, and then no surge in luteinizing hormone to bring about the ovulation. And then, like I said, increase in insulin, which causes insulin resistance, and then you have the metabolic complication like diabetes mellitus. So the clinical presentation varies. Like I said, right from the age of puberty. So from the adolescent period, polycystic ovary syndrome can present as menstrual irregularity. It may present as cosmetic concerns for the female, as when you have a lot of acne on the face, you have hirsutism, and interestingly, you can have hair loss as well, which we call alopecia. So you can have male pattern baldness. So you see a woman who is bald, and you're thinking like, you're asking yourself, what is going on? And then in the reproductive period, the most common presentation is infertility. And when the woman does get pregnant, you can have early pregnancy loss. And then during pregnancy, there's a tendency to develop pregnancy induced hypertension and gestational diabetes mellitus. And then in the the menopausal phase, that's after the woman has stopped her menses, then you can have the complications of the metabolic syndrome of polycystic ovary syndrome. So you have that can be diabetic mellitus, that can be a cardiovascular disease, that can be endometrial cancer that can come from polycystic ovary syndrome. The signs and symptoms, like I've explained, so it's just the same here, and I'm trying to break down hyperandrogenism. There's a lot of androgen in the system causing acne, causing hirsutism. The menstrual disturbance can be reduced menses, it can be absent menses. Fertility can occur from it. Obesity, hypoglycemia, which of course diabetes mellitus, the elevated estrogens, which also causes its own issues. You have dyslipidemia, that's a disorder in the lipid profile of the body, that's cholesterol. So you have hypercholesterolemia, hypertriglyceridemia, so all vary. So migraine can set, you can have migraine, that can be depression, insomnia, that poor sleep is very common. Also anxiety, male pattern baldness, can be acne, miscarriage, aggressive mood swings. And then all these symptoms are, it does not mean that these symptoms, and then you can have one person just having obesity plus polycystic ovary, or obesity, asceticism, polycystic ovary. So the symptoms are interrelated. I have explained this diagram. All right, so we'll talk about the menstrual pattern in PCOS. So like I said, polycystic ovary syndrome causes menstrual irregularity, and then the menstrual irregularity it causes can manifest in form of a longer menstrual cycle length. So you can, when you have menstrual cycle length, that's the length. When I say menstrual cycle length, that's the distance between the start of one menses and the start of another menses. So the number of days, when it's over 35 days, when it takes over 35 days for you to menstruate, PCOS might be the cause. It can be irregular. So of course, if you're not menstruating every month, then it starts to reason that the menstruation, you are going to have eight menstruation in a year or less, menstrual cycle in a year. Then interestingly, it can also come as a result of every period. Every menstrual period can also arise from polycystic ovary syndrome. And then when I explain that not at all, for 3 months or more, there can be no period. So all this menstrual irregularity can be quite confusing, but it is left for the physician to be able to take a good history and then try to find out. For the infertility, yes, this is it can be quite distressing for a woman who is trying to get pregnant. It comes with a lot of emotional instability. There's a lot of anxiety, family pressure, society pressure, especially in our society that places premium on fertility. So in gynecology, infertility is defined as the failure to achieve a clinical pregnancy after 12 months or more of regular sexual intercourse. And this definition will hold true for a woman who is less than 35 years. Or for a woman who is over 35 years before trying to get pregnant, I wouldn't wait for 2, because like the older a woman is, then the more difficult, the more likely it's going to be difficult for that woman to get pregnant. And for women with PCOS, the American Society of Reproductive Medicine found out that the rate of infertility amongst them is between 70 to 80%. So infertility is actually very, very, very common in individuals with polycystic ovarian syndrome. And like I said earlier, it accounts for about 80% of anovulatory infertility. What did I mean? For infertility cases, there are so many causes. But when the cause is due to anovulation, a woman who is not ovulating, 80% of that case, that anovulation is due to PCOS. So the contributory factors for the infertility that we found in PCOS, I've tried to explain in explaining the pathogenesis of PCOS. So the hypothalamic pituitary dysregulation in terms of the loss of the positive fashion of release of the hormone, and then the ovarian dysfunction. When I explain that there is no dominant follicle, without a dominant follicle, ovulation cannot occur. Without ovulation, then pregnancy cannot occur. Then insulin resistance, when you have insulin resistance, there's tendency to obesity. Insulin resistance also causes decreased cycle.
Dr. Halimah, we can't hear you again. Why are you trying to
Hello,
get... Yes, we
can you hear me now?
I can
Is
hear
it
you now.
better?
But yes, it's better. But we just want to take in a quick poll, then you can go on with the presentation. And so if you check your comment section, there's a form if you need more, if you need a more if you need a specialist consultation or you want to book any of the tests, you'd see a form in the comment section. And so we have the poll running in now. Dr. Halimah, you can continue.
All right, thank you very much, Dr. Gloria. So so you have obesity, which also causes ovulatory dysfunction. And like I said, pregnancy can be quite turbulent for a woman with PCOS. You have increased risk of miscarriage, and then the live birth rate is reduced. For acne, so acne is also a skin disorder. I hope you can hear me properly now. So acne is a skin disorder that is also commonly found in women with PCOS. Dr. Gloria, how's the sound now?
Yeah, sounds perfect.
All right, thank you. Acne is a skin disorder that is also common in women with PCOS. And then this is actually very distressing, especially in this age of where we place a premium on how we look. So I've actually had young ladies walk into the clinic because they have acne on their face and they've been trying to do all sorts of things and they're not getting results. And I'm sure that my counterparts in the dermatologist section also have seen this. As a matter of fact, the dermatologist also gets to diagnose polycystic ovary syndrome a lot from the skin manifestation of polycystic ovary syndrome. So acne is one of the classic symptoms of PCOS, and then it occurs when dead skin cells build up within the follicles, and then the high levels of the testosterone, the androgens that I talk about, testosterone and dihydroepiandrosterone, they overstimulate the hair follicles in the skin. And then you have the overproduction of this oily, waxy substance that you can actually feel on the skin. So when you now have a combination of sebum, that's the oily substance, and the dead skin cells, they clog the skin pores, the pores on the skin. And then this can allow proliferation, as in growth of a bacteria called the Propionibacterium acnes. And then this actually is what is responsible for the acne that we see. The high levels, the androgen, high levels of the testosterone and the dihydroepiandrosterone that is found in PCOS. For the diagnosis, like I said earlier in my introduction, there's been this there has been a disconnect in how do we diagnose PCOS. So you have different diagnostic criteria from different bodies, and then depending on what they use. But what we tend to use more in this part of the world is the Rotterdam criteria, which said that you just have to have 2 out of these 3. So this is the Rotterdam criteria here. So you have to have 2 out of these 3. There are 3 conditions here. We have clinical and or biochemical evidence of hyperandrogenism. So clinical evidence of hyperandrogenism is what I've been talking about, the acne, the hirsutism. The biochemical evidence would be a raised testosterone, dihydroepiandrosterone, when you take the lab test. Then you have oligo-ovulation or anovulation, which I have explained, which would come from the irregular menses, either too little menses or no menses at all, and then polycystic ovaries. Now, this polycystic ovaries can only be diagnosed on ultrasound scan. So this is it here, oligo hand or anovulation. Then the biochemical evidence, that's the one that is done in the test, where the total testosterone level exceeds that of 70 nanogram per GL. All right, and then you have the clinical evidence, acne, hirsutism, acanthosis nigricans, this hyperpigmentation that usually found in the armpits or at the back of the neck, and is usually more obvious in the whites, the Caucasians. And then for polycystic ovaries, now when you do a scan, the sonologist will see the ovaries, and then you just have, like I said, those small ovaries, small cyst follicles are in the ovaries. And they are arranged in a particular manner, which we call the string of pearls. So that diagnostic criteria for that, where you have about 2 to 9 millimeter in diameter, and they are usually more than 12. Okay, so unfortunately, this diagram. So this is the normal ovary here. So these are the follicles I'm talking about, that you know that, okay, these are the ovaries. But in polycystic ovary, you can see you have several of these cysts here, as in you can't keep counting, and then it is like a necklace. If you look at it closely, it's like a necklace, and that's what we call the string of pearls appearance on the which is quite diagnostic on ultrasound scan. So what are the investigations that we normally do for a woman with PCOS? So usually when you come with menstrual irregularities, whether I have not seen my menses or my menses is so irregular, we usually want to exclude pregnancy. We want to make sure you're not pregnant, because some will walk in and say, okay, let's say pregnancy. There's no way I can be pregnant, but really it is, we have to just exclude that. Pregnancy has to be excluded. So that's why we have to do a pregnancy test. And then the baseline, we have to do the lipid profile, that's the cholesterol, the triglyceride that I talked about, because in PCOS, you have metabolic syndrome where all these values are raised. Then the blood glucose level, remember I talked about the insulin resistance and then hyperinsulinemia. All these contributes to a high level of glucose. And then we do a thyroid function test, not because we use the test to diagnose PCOS, but we want to exclude other causes of anovulation, because hypothyroidism or hyperthyroidism, as the case might be, two of them, either hypo or hypo, have a great influence on the menstrual pattern as well. So you want to be sure that that's not what you are dealing with. And of course, the hormone profile. The hormone profile, anybody that has visited the gynecologist, we know that this is one investigation that we do a lot. And for the hormone profile, the LH-FSH ratio is usually greater than 2 to 1. Usually, you are not supposed to have more of the LH. So, but when you start having LH-FSH ratio that is greater than 2 to 1, then you should suspect polycystic ovary syndrome. Although the absence of LH-FSH ratio of 2 to 1 does not exclude polycystic ovary syndrome. And then the ultrasound criteria, which is what I have shown here, is also, we also request for it. So for the management of polycystic ovary syndrome requires a multidisciplinary team. It requires the multidisciplinary team. You need to have the gynecologist, you need the psychologist, the psychotherapist, the fertility specialist. We need a dietitian, because diet is central to the management of PCOS. You need an endocrinologist to manage the hormones for us. Imagine if the lipid profiles are raised or if sugar is raised. So you have a lot of people coming together. So the management should be multidisciplinary. We all work together as a team. And there's an algorithm I have here. You can see it clearly. Ignore the lean PCOS that I have here. It can work for any PCOS. Just have to tweak some things here. So central to the management of PCOS is lifestyle modification. There is nothing you try, whether any medication or surgery, if you do not modify your lifestyle, either in the diet you eat or in doing exercise, then you are not likely to be successful in the management of PCOS. So lifestyle modification, and then if that is not, if you are not getting enough result from there, then there are some other things that you can have, some medication like metformin. Metformin is an oral hypoglycemic agent. It's used by people who have diabetes. So we use it in PCOS for people who have high blood sugar, and also even for people who do not have, because we found out that it helps with ovulation. And then what is common now is also what has been found useful is bioinositol. So for asceticism, that's an excess here, you have a management with a mechanical mechanical management, shaving the excess hair, periodically electrolysis or by laser treatment, or we go the route of drugs, giving you oral contraceptive pills. To manage the menstrual dysfunction, we use oral contraceptive pills as well, or we use other medication like progesterone-based drugs, acne, other medications as well. And then there is the role of surgery. Surgery is done to when we just have to make sure that this woman, you've used all your pharmacological agents and it's not working, and then you have to do something like laparoscopic ovarian drilling to enhance the chances of the woman ovulating, because you want her to get pregnant. If all else fails, then we go the route of an in vitro fertilization. So for the weight management, like I said, central to this, to management is weight is a lifestyle modification, which two-pronged weight management and exercise. Insulin resistance is central to PCOS. So 70% of women with PCOS will have insulin resistance. And with this, you have a lot of insulin in the system, there is weight gain, increased body fat. And then what we have found out is that when you take diet that has a low glycemic index, glycemic index simply means that is a value that we use to measure how much specific foods increase blood sugar. So if I take this food now, how will this food increase my blood sugar? And that it has been classified as low, medium, or high glycemic food. So we want you to take a lot of diet that has a lower glycemic index that are better in losing weight than diets that has a high glycemic index. And then I have found this table here of drugs, of foods that have and their glycemic index rating. So you have here the grains, the vegetables, fruits, dairy, and proteins, and then you have the glycemic index of each one of them. And then I will be like foods that have the high glycemic index here that you should be careful of. Sweet potato, white rice, couscous actually has a high glycemic index. It's likely to raise your blood sugar higher than other ones. And interestingly here, people talk about wheat bread being very, very, very healthy, but look at the glycemic index of wheat bread is 71 here. And then you have other ones here. And in the fruit section, watermelon has a very high glycemic index. So if you are going to be taking watermelon, then you have to be careful how you take it. Watermelon in moderation, pineapple in moderation, grapefruit, apple, they are fruits that have a low glycemic index. And then for your proteins, the nuts generally have low glycemic index. Then it's good if your diet has to contain a lot of a high fiber diet, and then the daily diet of an adult should contain about 40 grams of dietary fiber, and also take about 4 to 5 servings of fruits per day. You need a adequate water intake, and also have gotten pictures of food that has a high fiber content, whole grain, green leafy vegetables, coconut are something as food that we can easily find in our environment, beans, peas, spinach, apples. These are things that we should incorporate into our diet. It helps with digestion. It helps in digestion. And then also fat. So right now what we are trying to do is to get a well-balanced diet. So, and when we are talking about a well-balanced diet, you're going to be taking carbohydrate, protein, fat, and oil, right? So you can't say, okay, you want to lose weight and then it's just you're going to do away totally with carbohydrates. All you need to is find out the calorie content of each one and take everything in moderation. All right. And then I have this picture here where I put the protein that are good for PCOS, the carbohydrates, and then the nuts. If you go online, there are lots of pictures that you can see. And then foods to avoid in PCOS, and generally food that we should generally avoid should be white sugar. We should do less of that, or we can totally avoid that. We should do that. Dairy products, milk, cheese, red meat, food with high glycemic index, and the white flour based products. Bread, for those of us that really like bread, they are not really healthy for us. And then this is actually a table that let's give you a guide of how you should plan your meal when you have PCOS and where you are trying to lose weight. And if you can see from this real plan, you can actually hit 1, 2, 3, 4, 5, like up to 5 times in a day. Now, I have seen somebody who said that she's been trying to lose weight. She has PCOS and she said she's been trying to lose weight, and all the things she has done, she's not losing weight. And I asked her what weight plan, what weight loss plan are you adopting? And she said she does intermittent fasting. Intermittent fasting should not be the go-to diet plan. It doesn't usually work, especially in PCOS, because the body has a way of compensating. So don't starve yourself. Your dieting does not mean that you should starve yourself. Rather, find a combination, a healthy combination of healthy food. So you can eat up to 5 times a day. There's no problem with that. Just make sure that what you are eating, you take your breakfast, you take snacks in between. Just make sure that what you are dealing with are healthy. All right. Then for the exercise helps a lot in increasing the sensitivity of the body to insulin. And then we find, so you don't have to start vigorous weightlifting. What we just did is moderate intensity exercise. Dedicate about 30 minutes of your time to moderate intensity exercise for at least 3 times in a week. And the exercise that have been found to be beneficial: brisk walking, stretching, jogging, yoga, dancing, cycling, and swimming. All right, let's just inculcate the habits of exercise into our daily routine, and then find that it's going to help a lot. So I've talked about the weight reduction. I've also talked about the importance of exercise in the management of PCOS. And in this table, I have kind of like, there is an algorithm as to when a woman has this PCOS, there are some things that we need to put into consideration. The weight of the woman, which is, so here when you have BMI less than or equals to 30 and a BMI greater than 30, that's obese. When you have greater than 35, that is a morbid obesity. So for women who are less than 30, or whose BMI is less than 30, and they have fertility in mind, like they are married and they're trying to get pregnant, there are things that we do. Our goal is to regularize the menses. We want to make sure that the menses are regular, because if we get the menses to be regular, then you are likely to be successful with your ovulation. So ovulation induction is central to the management of women with PCOS who are trying to get pregnant. And these are the ovulation induction agents that we use. And then when all this fails, then we go to laparoscopic ovarian drilling, and if everything fails and woman can afford this, then we do IVF. For women who are over, the BMI is over 30, weight loss is key. And a weight loss of a 10% weight loss, 10% weight loss has been shown to increase the menstrual function of that woman by about 50%. So as difficult as it is, if you keep to it and you do all the necessary things and you are able to lose at least 10% of your body weight, and it improves, it actually improves the menstrual function of that woman. So, but when everything fails, bariatric surgery, which is very popular in the developed world, has been adopted to facilitate the weight loss. Here also is just a diagram to kind of like point us to the kind of diets also to adopt when we are talking about trying to get pregnant and then we have a PCOS. For irregular menses, like what I said earlier, central to what we use as gynecologists is the oral contraceptive pills. We tend to use that a lot. It's like the go-to choice. And then you know that the oral contraceptive pills, what is commonly known about it is that it is used to prevent pregnancy, but it has other functions. And these are the functions that we use. Functions in the sense that it regulates the hormones so that the menses can be regular. So we use that. We use oral contraceptive pills to ensure that the menses are regular. And then when there is hirsutism with the as a presentation, then the kind of oral contraceptive pills that we use, we still have some other drugs to use. So it's like dual. It has a dual function.
Okay, thank you, Dr. Halimah. Sorry to cut you short. We want to, if you can just wrap up in like the next 1 or 2 slides so that we can take in question and answers.
Yes, so, okay. All right, thank you. So, also for acne, eating well will help with the acne, seeing a dermatologist will put you through. So in summary, I have talked about PCOS, I have talked about the many phases of PCOS, obesity, infertility, menstrual irregularity. I have also talked about the management of the symptoms, what we use to manage when we have hirsutism, infertility, obesity, menstrual dysfunction. I have tried to talk about the sequelae, that's the complication of PCOS later in life, that it can cause endometrial cancer, it can cause cardiovascular disease, and then diabetes mellitus. And also it has been found that women who have PCOS, their offspring can also have PCOS, and their offspring can also develop some metabolic diseases like type 2 diabetes mellitus and cardiovascular disease. So in conclusion, you don't have, when you try on this weight loss journey or in the management of PCOS, what you should be aiming for is not perfection, but your effort counts. So when you put, so they say little drops of water makes a mighty ocean. So you implement all this effort every single day, and then the transformation will happen, and then change occurs. So just remember, one step at a time, don't give up, and just keep going on, and then you will smile at the end of the day. So for women with polycystic ovary syndrome, I would like to say that you are not alone in this. A lot of people are in support. So if you have any of this, please try to see your gynecologist sometime, and we will start the journey with you. So you are beautiful inside and out. Stay strong because you are worth it. Thank you very much for listening.
Thank you very much, Dr. Halimah. I'm sure we can all agree that that was a well broken down overview of PCOS. And so there's a poll on your screen. Just kindly pick the appropriate answer. And so we'll just move on to question and answers session now. I've seen a lot of questions already, and so we'll just take it up from there. And so a question says that, is there any link with PCOS to blocked fallopian tubes? And are there any natural remedies to assist with PCOS? So I'll just join some of the diet questions together. Then the second diet question says, does PCOS have anything to do with lactose intolerance?
Okay. All right. So do you want me to answer each question?
Yes, please.
Okay. So for the first question of a link between PCOS and blocked fallopian tubes, no. So what causes the blocked fallopian tubes are different. Infection, surgery around that area, conditions like endometriosis that will cause adhesions that can block the fallopian tube. But for PCOS mechanism in causing infertility is because of no ovulation and ovulation. And like I said, you need that ovulation you need to ovulate for you to get pregnant. So PCOS on its own does not cause blocked fallopian tube. And for lactose intolerance is like something we call this in biochemistry. No, PCOS does not cause lactose intolerance. All right, it's not a condition that is known for lactose intolerance. It has its own a list of metabolic syndrome, but I didn't come across PCOS in lactose intolerance. Thank you.
Okay, thank you very much, Dr. Halimah. And so if you check the comment section, there's a link if you want to do any of the tests or you want to book a specialist appointment. And so for further questions we've had so far, someone is asking, is it possible to have PCOS without any pain? As she has thought that people who have PCOS are usually in lots of pain. Then another question here says that I was diagnosed with PCOS and ovulatory in April. I have followed healthy lifestyle. However, our menstruation cycle is 37 days. And even she has also discovered that weight is still the same, but measurement is different from her former measurements. What could be the cause? She feels that she has lost weight, but her measurements are still the same. And her cycle length is about 37 days.
Okay, so for this, let me take the last one first. So for this lady, that's a common complaint that you hear in PCOS, that they've tried everything and then they are not losing weight at all, or they are not losing weight as quickly as they want to lose weight. So she feels that she has lost it. So probably just check the scale. But for how long has she been trying to lose the weight? So the thing about this is consistency. And then, like I said, it's possible that all the lifestyle modification may fail. So at this point in time, then we have to go and try medication. So it's very important that you walk this journey with your gynecologist, who at a point in time will now tell you that, okay, so this lifestyle modification is not working. We need to get in medication to help with the symptoms you are having. The other, sorry, I think I lost the other question. What was the other question, Dr. Gloria?
Okay. Let me just remember. Okay, while we're working on that, there are a lot of questions if PCOS can be permanently cured. And
PCOS has no cure.
Okay.
It has no cure. It's a condition that you have to manage. It does not have a cure.
And so people want to know, what are their chances of getting pregnant in the future? Does it mean that they'll be permanently infertile, or there's a possibility that they can still get pregnant?
There's a possibility that you can get pregnant. So like I said, not all, okay, I don't know if I said this, but PCOS, the severity of symptoms also varies. So you have people with mild PCOS. You have people with PCOS that actually ovulate. Then you have people with PCOS that have mild symptoms, that all you just need to do is just help with some ovulatory drugs and they get pregnant. A lot of women with PCOS get pregnant. So all you just need to do is to start on time, see the specialist on time, and then you start walking the journey together. But that is not, it is not 100% that you will not have a baby again.
Okay, thank you very much, Dr. Halimah. So someone is asking that, does PCOS reduce the possibility of having a successful IVF? And second one, yes, can it lead to ovarian cancer?
Okay, so for the successful IVF, yes, for the successful IVF, PCOS actually affects the success because you have a lot of small ovaries. So what we do in IVF is to stimulate ovulation. So we hyperstimulate the ovary. Now imagine that you have a lot of small ovaries. By the time you start using all those drugs, there is the possibility of developing what we call the ovarian hyperstimulation syndrome. You understand? At a point in time, you may even have to abandon that cycle because you don't want to push the patients to having OHSS, or you have to modify a lot of things. So it does affect, it actually affects the success of IVF. And then, sorry, the
PCOS causing ovarian cancer.
Ovarian cancer. Well, there has been no chronic anovulation in itself is a risk for ovarian cancer. For ovarian cancer, as in repeated ovulation, is a risk for ovarian cancer. But for PCOS, what you have is anovulation. So for PCOS, what has been found is endometrial cancer. What has been linked to PCOS is endometrial cancer. Ovarian cancer, breast cancer have not been linked to PCOS. So no. I hope I have answered that.
Yes, you have. So as we've all heard, PCOS has not been linked to ovarian cancer. I'm just trying to go over more questions. And so for asceticism, someone is asking, tweezing or laser treatment, what do you suggest? And is asceticism reversible? That's excess amount of hair in the body.
Yes, okay. Laser treatment, what do I suggest? So there are many ways of treating asceticism. Laser treatment has been found to be effective in managing the asceticism of PCOS. So it just depends on what you have access to and then what works for you. So laser treatment, fine. If you can get access to it and it's working for you, fine, go for it.
Okay.
Right,
And
is
so
the question,
skip your,
yes,
okay.
Dr. Gloria, and then the person is saying that she had intermenstrual bleeding and then she was asked to go for, and the doctor said it was borderline PCOS. And her menses are resumed. So it's also pertinent, as in I picked this question because there are so many causes of irregular menses. All right, so it doesn't mean that when you have irregular menstruation, whether you are not bleeding or you are not menstruating enough, it does not automatically mean that you have PCOS. So there are other causes of irregular menstruation. So the best thing is for a doctor to diagnose exactly what is causing this the irregular menses and then for it to be treated appropriately. All right.
Okay. So just to move on with the question and answers segment, there's a question, does PCOS trigger high blood pressure, high sugar? So we've mentioned it already that one of the complications of PCOS is metabolic syndrome, and so there might be abnormal blood glucose levels, and insulin resistance has also been linked with PCOS. And so Dr. Halimah, if someone is asking, is long-term use of OCP safe in teenagers? Since OCPs is one of the treatment option for PCOS.
Okay, so when we use OCPs to regulate the menses, there are particular ways that we use it. You can use it in a continuous form or you can use it in a cyclical form. You can use it for 3 months, sometimes you use it for 6 months, sometimes you use it for 9 months. But what we tend to do is once we have the desired results, we tend to stop the OCPs. We tend to stop the OCPs, and it's a safe enough drug for teenagers. Yes, we can use OCPs. We use OCPs in teenagers as well. It has been giving us excellent results. Yes.
Sorry, Dr. Halimah, we didn't hear the last part. Your voice was quite low.
Oh, okay. Can you hear me now?
Yes, we can hear you now.
So I said when we use OCPs, so there are different ways we use OCP, either cyclically, or continuously, where we just say, okay, take this, there are 21 pills, hormonal pills in OCP, and then 7 iron tablets. So when we use OCPs, we can do it in such a way that you can use it for 3 months, or you can use it for 6 months, you can use it for 9 months, until we get the desired result. So we tend to use it, and then evaluate, and it's safe. We use it in teenagers, and it's safe. It's safe.
And so there's a question, how can someone with PCOS get pregnant? So over the course of the presentation, there have been several methods that has been listed, such as ovulation induction, and if it fails, there is IVF. But I'll leave Dr. Halimah to shed more light on that. How can someone with PCOS get pregnant?
Okay, thank you very much. PCOS and infertility. So the first step is for us to induce ovulation. Because if you can't ovulate, then the chances of getting pregnant is increased. So we try to make you ovulate. And in ovulation, we can use ovulation-inducing agents like clomiphene citrate, letrozole, and some other drugs. When that fails, we can do a kind of a surgical procedure, which we call the laparoscopic ovarian draining, where some points are made on the ovaries that can help with ovulation. When that fails, then there is the option of in vitro fertilization, which we call IVF, and of course, there is adoption as well.
Okay, thank you so much, Dr.
And there's also surrogacy, as it's something that is really gaining ground in our environment now, is the option of surrogacy.
Okay, you mentioned letrozole. There's a question on that. So the anonymous attendee is saying that a gynecologist said ovarian cyst was caused by letrozole, which she was taking to improve her ovulation. However, she had to discontinue it and she's trying to conceive. And so is there an alternative? And so because this is an educational session, what works for A might not work for B. And so we cannot just prescribe a drug for you to take. And so you need a detailed consultation later on, but I would let Dr. Halimah answer the question.
Dr. Gloria, you have answered that question already. Really, what works for him might not work for B. Like you said, letrozole is just one of the agents that we use. And if it's causing ovarian cyst, probably she has a large cyst and the gynecologist is concerned. So I would say you should still see your gynecologist and you should sit down and talk about the treatment plan. So what are you doing about the ovarian cyst? Are you draining it? Are you waiting for it to resolve spontaneously? Are you doing surgery, or are there alternatives to conception? So these are all the questions that you have to discuss. You have to ask your gynecologist, and then you have to have a clear plan forward.
Okay. And so we're getting to the end of the question, to the end of the Q&A session. There's a question on natural ways to cure PCOS or natural remedies to assist with PCOS.
Okay, so for the natural remedies to assist with PCOS, it has to do with your diet. So there are some natural substances that have been found to help, something like fenugreek, chia seed, cinnamon, all these things where you take them, they also help with the hormonal milieu of the body. So it can help with menstrual irregularities, can help with ovulation. There are quite a number of natural remedies that you can use that are all mostly plant-based. And then I encourage people to inculcate them into their diet. So I think what I can clearly remember now, I can remember the fenugreek, like I have mentioned. Chia seed has also been found to be good. So that a lot. So just you can check that, can find out. But natural remedies help, but there is no cure, like I said, for PCOS.
Okay. Thank you, Dr. Halimah. Before we take the last session of questions, I'll just go over what Dr. Connect is for those of you that were not in attendance from the beginning. And so Dr. Connect is a telemedicine organization who is on a mission to use mobile and disruptive technology to make healthcare instantly accessible. So we offer 24/7 round-the-clock consultation. So once you download the app from the Play Store or the App Store and you sign in, you get 30 days free trial to speak with a doctor at your convenience. We also have a lab located in Adol House, 15 CIPM Avenue, Allows, where you can do some of these tests, the hormone profile, the blood sugar, the lipid profile. And if you also want a specialist consultation, there is a link in the comment section that leads to a form where you can fill in if you'd want any of this done. And so one of the last questions I'll be asking Dr. Halimah. Dr. Halimah, thank you very much for your patience and your time. And so there's a question, does using abortion pills causes PCOS, and what other damage can it cause?
Abortion pills, no. Abortion pills. So I want to be, okay, so the person just wrote abortion pills, but no, abortion pills does not cause PCOS. And really, this is something that should be discouraged, really. So abortion pills should be discouraged. These are drugs that are highly regulated and should be given by professionals. And what we find in our society now is that these pills are really, really, really abused. So people just walk into roadside chemists and they buy some of these drugs, which has a lot of detrimental effects. You can use it and there can be excessive bleeding if not well controlled. And then when you lose a lot of blood, it might be too late before getting to the hospital. So I would say, please say no to unsafe abortion. All right. So if you don't want a baby, then try to prevent getting pregnant. So how do you prevent that? Abstinence is key. Stay away from sex if you are not ready to get pregnant. And if you can't hold body like they say, then prevent pregnancy. That is my message. Thank you.
Thank you, Dr. Halimah. So someone is asking for, so basically preconceptual care. She's about to get married in a few months and she wants to get pregnant immediately. Are there any preparation drugs that she can be taking in the meantime?
Okay, well, I was just sending the message to her now. So really, preconceptional care is something that we've not really we didn't pay premium to in our environment, and which is very important. So what I asked her was if she's overweight. What I told her was if she's overweight, she should try to lose weight, she should try to eat healthy. That is, she should not start taking medication now. What she needs to start taking is folic acid. Folic acid, good diet, exercise. That's what she needs.
Okay. Thank you, Dr. Halimah. So I've all heard folic acid supplementation is a very important drug, especially when you are considering pregnancy, as it has been shown to reduce some brain defects in the baby. And so thank you very much, Dr. Halimah, for joining this webinar. I'm sure that it was very informative and very entertaining. And so there's going to be a last poll, just have an idea of what we've learned so far, to see if there's an improvement from the beginning and now.